Son of antimicrobials. How identify the areas for improvement. The basic data collection example includes what is the prevalence of inappropriate antibiotic usage, example treatment of asymptomatic bacteria or dual anaerobic therapy in others. What is the lag time between culture sensitive and effective therapy? How often are positive blood cultures not covered with therapeutic agents? For patients who are converted to oral antibiotics, what are the percentage of conversion? Do we have the data on percentage of patients who achieve antibiotics for more than 3 days and other such areas for improvement? Find the possible projects from the same. IV to oral switch, the most basic stewardship function. Ensure all antibiotic orders carries an indications. Reassess all the antibiotic therapies at 72 hours. Have the bug drug mismatch. Get the daily culture report. Assume that the bacteria that is discourage the antibiotic usage. Educate the clinicians. Sepsis have sepsis campaign. Get cultures before antibiotics are administered. Check daily blood culture reports. If contamination is highly suspected, work toward discontinuation. The pharmacy staff schedule the in-services to reinforce antibiotic usage guidelines, includes beta-lactam selections, prescribed education is important, goals to maintain the relationship with quietly changing prescribing patterns, education seminars, daily rounds, and nursing appropriate results for cultures, microbiology, antibiotic templates which may improve prescriber education, consider combined antimicrobial rounds, feedback on patient outcomes. Framework for study research assessments includes interventions such as baseline assessments, identify the specific and measurable outcomes, involve the key stakeholders, design the interventions with team inputs, evaluate the interim results, modify the interventions as needed. Don't forget stewardship opportunities with treatment of fungal infections. Formulary echinocandin choice, therapeutic interchange opportunities are among the low-hanging fruits. As we move to the high-hanging fruits, IV to oral conversion of fluconazole as well as oronazole, ensure acidic gastric environment for absorption of some agents, switch to fluconazole from other antifungals for candida albicans as appropriate, identification of candida albicans, susceptibilities of albicans and non-albicans and others. All patients who receive targeted oral and IV antibiotics are monitored for opportunities for change. Optimization can be protocol driven. Monitoring the patient responses avoids a single observation point in time. Correction of the underdose regimens. Pharmacodynamic modeling consider the sites of infection, pathogen specific MIC, and look for opportunity to employ extended. This is how the form for the IV to oral conversions looks like. The therapy committee has to approve the patient's meeting, and the following criteria can be automatically converted from to an oral version of a listed medication. An example of a labeling and registrational education and timing of administration, co-administration of an oral fluoroquinolone with divalent or trivalent cation containing compounds inhibits the fluoroquinolone absorption. Efforts should be directed at modifying the hospital policies for dosing oral fluoroquinolones and DTCCs to prevent co-administrations. A simple community acquired pneumonia audit was followed, and it was observed that cost differences between audited antibiotics versus compliance with guidelines. Goal is to minimize the surgical site infection rates, decrease the variability, compliance with the SIP measures, and follow national guidelines. Opportunity for stewardship include education on recently published guidelines and changes from previously. Examples of stewardship projects involving SCP measures include progress project addressing specific performance, reason to optimize the performance, drug selection, duration, education, and special circumstances. High hanging fruit can take into program examples also such as optimizing antibiotic selection, then use of a clinical pathway to improve the empirical antibiotic therapy, then decreasing the antibiotic duration and patient level resistance, then de-escalation, that is streamlining the therapy to narrow spectrum agent based on culture results. So serious infection is suspected, begin the empirical therapy, pathogen is been identified, de-escalate antibodies based on the culture sensitive results, and search for super infection, abscesses, formations, non-infectious causes of symptoms. If there is no significant improvement, if there is a significant improvement, discontinue antibiotics after 7 to 14 days of therapy. If there is no pathogen identified, continue the initial treatment, reassess with appropriate time. Avoid antibiotic combinations to reduce redundant therapy. When getting it right, empirical lack of evidence for the most part may increase the probability of adverse events and increase the cost. Evaluate antibiotic therapy at different time periods for stewardship opportunity. Prospective controlled interpreted time series in a single test center was observed, and it was observed that institution of a formal prospective audit and feedback program appears to be safe and effective means to include a broad spectrum antimicrobials in critical care. There is in a study it was observed that there was a significant association at the less than 1 hour time point for mortality with early goal-directed therapy, which included appropriate. Shorter antibiotic courses matter. Goals of reducing the duration of therapy includes decreased selection of the resistant pathogens, decreased C. difficile infection, decreased antibiotic-related organ toxicity, decreased hospital costs, improved compliance, and potentially early removal of catheter. Guidelines support treatment of many inpatients with shorter courses of therapy, which includes community-acquired pneumonia in adults, hospital-acquired or healthcare-associated or ventilator-associated pneumonia. The short course versus extended course therapy for mild to moderate CAP guidelines needs to be followed. Duration of therapy was observed in 8 days versus 15 days, and it was observed if the patient responds rapidly and the acute pathogen susceptible to the initial regimen, therapy may be altered to early 7 to 10. Guidelines support treatment of many inpatients with shorter courses of therapy. It was observed through a study on UTI. Diagnosis, prevention, and treatment of catheter-associated UTI in adults was studied, and guidelines support treatment of many inpatients with shorter courses of therapy. Guidelines also support treatment of many infections with shorter therapy in intra-abdominal infections. Empirical therapy of patients with complicated intra-abdominal infections requires the use of antibiotics at optimal doses to ensure maximum efficacy and minimal toxicity to reduce the antimicrobial. Skin and soft tissue infections requiring hospitalization are opportunities for stewardships. Optimizing antibiotic dosing using pharmacokinetic and pharmacodynamic principles are studied, and it was observed that once a daily dosing aminonucleic acid is required to prolong infection or short half-life of beta-lactam as per the principles of pharmacokinetics and pharmacodynamics. Prolonged infusion of beta-lactams with short half-lives optimizes the pharmacokinetics and pharmacodynamics. As said earlier, dose escalation either by administration higher doses or I choose only small increments of efficacy because there is little increase in the time. To remove the drug concentration exceed the MRC, and extended time infusion for carbapenem increases time drug concentration exceeds the MRC compared with the shorter. Optimize the clinical outcomes using prolonged infusions of beta. Now, what is the potassium project focusing on outcomes? How frequently is the metronidazole being prescribed to peptides, carbapenems, and others? Does the antibiograph eliminate duplicates? Is there an ability to classify the isolates on the antibiograph? Are you familiar with the medical staff understanding of antibiotics? What is the frequency of prescribers? And many other such questions needs to be studied, focusing on prolonged infusions of beta-lactam antibiotics or also needs to be studied for the implications of antimicrobial stewardship because it is essential to combat antimicrobial. What are the common barriers in studies? The lack of resources, staffing such as pharmacists and physicians, funding, IT resources, clinician base, and cultures, such as antimicrobial stewardship is not a. However, the survey it was found that only 26% of the hospital stewardship program monitored clinical outcomes such as mortality and length of stay. The other focus was on direct drug expenditures and pharmacists. The dilemma is that the number of ID trained clinical pharmacists doesn't match the demand, nor do the number of training programs. Requiring completion of a postgraduate ID training program to administer stewardship would be an impediment at possible delays in appropriate therapy, lack of dedicated approval, improperly prescribed unrestricted antibiotics, overall increase in time from decision treat, requires process to be monitored. Clinical significant differences in information provided on the call which is inaccurate is likely to affect the antimicrobial. If stewardship program operation is restricted to certain on-service hours, prescribers may wait until off hours to order restricted antibiotics. Restricted formularies may encourage creativity when prescribers want to circumvent restrictions. Creates anonymity between stewardship program and senior professionals who may value decision-making autonomy rather than giving up decisions. When cultures do not help, between 65% of the cases, cultures were not helpful in streamlining treatment. How the possible solution is use the guidelines and local antibiotics to streamline the therapy. Therapy altered based on culture and cultures are supported by observation 27% in the study, while in 65% cultures were not helpful. Therapy was not altered despite the culture results in 8%. Thank you.